So prostate cancer is the most commonly diagnosed cancer in men. It accounts for 1/3 of all cancers that men can have. And it used to be the second leading cause of cancer-related death in men after lung cancer. It's now the third leading cause after colon cancer. And I do credit that drop from number 2 to number 3 because of the use of the PSA test, although there's a controversy about it, and I'll get to that in a little bit. So it's a very prevalent cancer. At this point in time, about 200,000 men on an annual basis being diagnosed with it. One person is diagnosed every 2 to 3 minutes. In terms of our annual healthcare cost burden, it's about $8 billion, so it's very expensive, not only to diagnose these men, but potentially also treat them. We jump to 2015, there'll be 300,000 men diagnosed with it on an annual basis, about 3 million men living with it worldwide, and about 50,000 men dying from prostate cancer on an annual basis. To give you a little bit of perspective, that's the same number of men died throughout the Vietnam War over a 20-year time span. So that's a lot of people that are impacted with the disease. But that's not to say that every person that gets diagnosed with it necessarily needs treatment. There's been a lot of controversy with regards to screening with the use of the PSA. This past October, the U.S. Preventative Task Force issued a statement actually discouraging the routine use of PSA for prostate cancer. And it's caused a lot of concern among not only urologists, but healthcare practitioners and patients. And I think you have to use the PSA test intelligently. The reason the U.S. Preventative Task Force came out with that recommendation is based on 2 large trials, one performed in Europe and one performed in the United States. The European trial, the ERSPC trial, followed almost 200,000 men over a 9-year time period and did note a slight improvement in survival in men that had undergone screening with the use of PSA, although the U.S.-based trial did not notice the same results. And there's been a lot of criticism and limitations of those trials in the sense that they didn't follow patients long enough, and there was a lot of contamination with pre-screening in both trials, so you wouldn't see as big of an effect of screening. I, as a urologic oncologist and as member of the American Urologic Association, agree with the guidelines that we came out with in 2009 that all men starting at the age of 40, regardless of their family history, but certainly if they have a family history of first-degree relatives diagnosed with prostate cancer, or if they're African-American men, should get a baseline PSA test and use that baseline to counsel them in regards to how frequently they should obtain other PSA tests to rule out the possibility of having potentially lethal but treatable and curable prostate cancer if it's detected early. Where I think we're headed is beyond PSA. I think PSA test is not a great test, but it's the only test to really have at this point in time clinically available. We're going to head towards other either urine-based or blood-based markers to give us a analysis of a man's risk of prostate cancer, and if they certainly have prostate cancer, what their risk of having any harm or dying from that disease is. Because not all prostate cancers are equal. There's certainly some cancers that will not grow fast and will certainly be present even when a person dies 15 or 20 years down the line, while there are very biologically aggressive cancers that can potentially spread and metastasize and kill someone in a very short time span. In the past year, there have been a couple of articles that have come out on urine-based markers looking at gene changes. One of them was Tempus ERG22, gene changes in urine tests of men, not only being a better predictor of who has prostate cancer, but who has clinically significant prostate cancer, meaning Gleason 7 or higher grade cancers that have the potential to cause harm down the line. Another study that came out this year is a 5-gene lethal prostate cancer test that can accurately differentiate between early lethal or aggressive cancers and dormant type of cancers that could certainly be followed through a program called active surveillance. I'm a big proponent of active surveillance for men who are appropriate candidates for it. Early risk, Gleason 6, small amount of volume, with not many cores involved. And what we've seen from a wide variety of studies, both from the United States and through Canada, is that a lot of men with early cancer that is deemed to be low risk can be followed expectantly and not undergo unnecessary treatment with either surgery, radiation, or any other ablative techniques. So I think we're going to get a lot more tests in the future, whether it be urine-based or blood-based, that can give us a better assessment of what type of cancer, if they truly have cancer, a person has.